Oh, Chris.
Hey Chuck, what's with the low energy over there?
Oh, I'm full of energy, full of energy. It's a great day, and we're doing some podcasting today. This has been great.
Absolutely, I'm excited because we have some couple of our friends. They are pandemic friends. The family we spent a ton of time with. They're out of town, and they actually had their kids stay with us. Um, and oddly enough, I love cooking for them, but their kids ate all the food I made last night, and my kids didn't. And it reminded me of last weekend when I made this huge feast and it was delicious and everybody loved it. My kid made himself a ham and cheese sandwich. I'm like, come on, man.
You can only hope it comes full circle.
Exactly. Well, I have a funny story to share. I have a patient who I saw yesterday for the first time. And she said, "Oh yeah, I used to see Dr. Goldfarb." I was like, "Oh, interesting." And the last note from you was in 2013, so she clearly was a new patient to the group. She's like, "Yeah, I tried to call and see him, but he only sees children now." So I said, "Yeah, you're right. He's really focusing on that." Blah blah blah. We were talking about her thumb CMC arthritis, and um, I remember I was like, "Yeah, I saw that Dr. Goldfarb had injected this in the past. Do you want another injection today?" Blah blah blah. And we were just talking about options. And then she's like, "Yeah, I really love Dr. Goldfarb." I was like, "Yeah, he's great. I'll let him know." And so I was doing her injection. And as I'm injecting her, it was her left thumb. So then in order to inject her left thumb, I actually kind of like, went sidled up a little bit next to her in order to, place my hand where I needed it to be. And she's like, "You're smart." She's like, "I think the last time I got an injection from Dr. Goldfarb, I kicked him."
And that's why I wasn't allowed to come back.
Exactly. But then I told her that we do a podcast together. She's like, "Well, how do I find it?" So I almost, and I've done this with one patient in the past. I'm shameless. I'm like, "Oh, give me your phone." Pulled it up, immediately clicked 5 stars.
That's really funny. We are always looking for podcast topics and kind of how to record. You and I are working on a strategy since we're both going to be in London at the IFSSH. We're going to try to do a live podcast there, which could be super fun. So if any listeners are going to be in London and it sounds like a good idea, let us know.
Yeah, this episode I think is going to be dropping right on the eve of the meeting almost. So what we're recording now. So, stay tuned to social media. Look out for any plugs on that in terms of maybe you'll be able to catch Chuck and I doing a live podcast, or you can throw your shoe or whatever at us if you like.
We're going to try to bring some swag if that's any incentive.
Yeah, we talked about how the TSA is going to ask us why we've got so many. I won't spoil it, but so many things that say the upper hand on them.
Absolutely. So we have a good topic to discuss. You want to introduce it?
Yeah, so we talked in our last episode about the folks at Stanford and our good friend Jeff Yao. And so Jeff had binge listened to us before and we've shouted him out, but he sent a great topic in. So he has a topic about how to navigate the difficult patient, because we talked in one of our past episodes about the therapeutic imaging that we sometimes get. How do you handle the opioid seeking, red flag patients with real pathology that need treatment, et cetera? So Jeff is clearly seasoned, experienced, and is asking for some help. So it shows how this is something that affects everybody at all times. I think that these are really tough patients.
These are tough patients. There are no easy answers. I think about this a lot because as you know, one part of my teaching style is just hopefully doing things correctly and then maybe talking about them. I guess that's everyone's teaching style, but let me give you an example. And so we had this conversation in clinic this week. I've clearly, none of us have always handled this correctly. And we all worry about negative reviews, right? It's just a fact of life. And we can talk about how do you drown out negative reviews with positive reviews. But let's take an example of something perhaps I did not do well. Every patient we have to assume that comes in the office legitimately feels like they have a major problem and needs a solution. And we, as their physician, I think have to accept that. Doesn't mean we have to agree to it, doesn't mean we have to do surgery on it, but we have to acknowledge that, give credence to that, and manage that. And I have failed sometimes to do that. And I think that's largely a part of having a busy practice and feeling like I'm being pulled in different directions. And I can think of one patient who roasted me on a review. This was a patient who had really minor, non-painful Dupuytren's that I don't remember the interaction, but I told them that they don't need anything done for this. And hopefully it's not going to get worse. And it wasn't a negative interaction in the office, but clearly I did not accomplish what needed to be accomplished with that patient visit.
Yeah, and it's unhappy patients are more vocal than happy patients. Although our happy patients clearly tell you to your face they're probably not going to go the extra mile and leave a review unless you make it very easy for them. But yeah, I agree. Some people need to be heard, need to feel validated in terms of their complaints. And I think we have to trust that people who come in, who take the time out of their day to come in with or without a copay or whatever it is, have something that they want addressed. It clearly has risen to the point where they need to come in. Some people, the minority people, just want to know what something is, but usually people are seeking some kind of treatment. And I too have fallen into that trap of not giving people's issues enough credence. And I hear about it now, not only through the online reviews, but through the Press Ganey thing that we're doing now. Every month we get, a survey for better or worse of how we're doing. And that includes free text feedback. And, I remember talking to a patient about, I think it was stiffness after a distal radius fracture. And complex fracture, didn't regain full flexion. And they were talking about how they wanted to gain more flexion. And I, quoted the classic stuff saying, you really, honestly, you don't need a lot of flexion. I'm more worried about you getting extension and anything else to a more functional position. The stuff that many of us as therapists and surgeons will say to patients. And I got knocked for that, saying that, I talked about how much I wanted to bend my wrist and Dr. D didn't care. Like you mentioned, that was more important to have more extension. And I was like, oh man. And then I recently had a patient who, literally there's nothing to do for this patient, but I did not spend enough time. So they're coming back in so I can spend time with them.
It's interesting. And we want to I think we haven't jumped to Jeff's question or comment about the difficult patient or narcotic seeking patient, but let's talk about some of the ways that you and I approach this type of patient, not necessarily needing in a malignant way, pain medicine or whatever, but just needy, I guess we might call them. It starts with the basics: sit down. It increases the perception of time spent with the patient. That's a no-brainer. Always sit down, always touch the patient. I took the two easy ones. What else?
I think it's understanding personalities. We talked in our last episode about generational differences, but it's not just generational, it is just personality differences. You can tell how somebody wants to interact with you, whether they're more kind of direct and straightforward, like you and I think tend to be, or whether they want to feel heard and really letting them go. And I know that there's the classic thing we talk about when doctors ask patients a question, we cut them off after like 7 seconds. I am really trying to let patients talk and understand why they're here, understand what bothers them about what, I'm awful at this with like ganglions. I try to understand what they want out of this, what they can't do. In orthopedics, largely we have the pleasure of getting people back to doing what they want to do. And I think that understanding what people want to get back to, kind of their values, their compass of activities, that what makes them tick.
Yeah, I think that's a really good. I have a couple more, and then I have a humorous, hopefully humorous anecdote. I think you're gonna judge me. Let me say the easy one first. The easy one is never let a patient leave without asking if they have questions. But to me, and Aleem actually pointed out that I said this differently than that. And I do say it differently than that. I don't finish a visit by saying, do you have questions? I finish a visit by saying, what questions can I answer? I think it's a subtle difference, but it is a difference. And hopefully it does. And generally the answer is no. But I think it does frame things differently for the patient leaving the office.
You took mine, because I make a conscious effort to end the visit with, what can I answer for you? And that's when I'm sitting down, because it's very different if you are one hand on the door, you're standing up, and you have any questions?
which I'm guilty of sometimes.
Right, and I do the same thing, but I make it conscious. I was actually thinking about this yesterday. I make a conscious effort to end the visit with, what can I answer for you?
Yep.
Because it's very different than, do you have questions?
All right.
So I agree with you on that.
Here's my corny one. And I do believe this. I think it's going to get some chuckles out there in the pod listening world. So wearing a mask has emphasized to me kind of the importance of your eyes and your connection visually with patients. I believe, this is where it gets corny, that you can show empathy with your eyes. And I think your visual engagement and kind of your expression with your eyes can say a lot. And I'm still wearing a mask in clinic and will continue to indefinitely. I think you can do it, and I think it matters. And I try to do that with every patient.
Well, I think you have to make an active effort to do it. So I'm glad you stopped wearing sunglasses in clinic.
Red flag.
Well, we talk about red flags. I mean, yeah, if somebody, well, you can tell a lot about somebody from their eyes. And when patients do come in sunglasses, I'm like, oh, okay, this is what we're. So to pivot to Jeff's question, this is given the specialty that I have chosen of being in peripheral nerve and being a bit welcoming and inclusive with the kind of patients I see all sorts of weird stuff. And that to get into, it's not hard to get into the complex nerve clinic at WashU. So, which is a clinic that I share with David Brogan. And he's like, what are you seeing? Like, how are these people getting in? But he and I, and this is a bit callously framed, we're much more sensitive than this, but he and I have this constant debate of, is it better if the crazy patient has real pathology, or is it better if the crazy patient doesn't have real pathology? And this kind of gets to Jeff's question. So what do you think?
I think we have to assume that every quote unquote crazy patient.
Yeah, I know. I should have used the quotes. You're much more. This is why he's the executive vice chair and I am the lowly associate professor.
It is. I think we have to assume that every patient has pathology, and of course that's not true, or may not have treatable orthopedic pathology. We have to assume, which is better. I am, when I think a patient is a challenging patient for whatever reason, and I identify a pathology and treat it, there's nothing more satisfying to me. And I mean that. I really mean that. And I think it's important for me, it's important for the patient, and it's most important for the trainees.
Right. I mean, I think that, some of the most gratifying cases I've had have been patients who I think a lot of people have written off just because of the way that they come across. But that is the patient where you just spend so much more time because you're trying to develop a relationship. You're trying to trust them and they're trying to trust you. I think that is where additional testing is useful, to be very honest with you. Objective findings are very useful. I saw a patient recently who has seen other well-regarded peripheral nerve surgeons and has been written off. I think it's because of their personality. But I think that the testing and the examination and the consistency of that story over time say a lot. And I think that while that patient may be written off and dismissed by other folks, the fact that they've got identifiable objective findings on testing and consistent examination and history speaks volumes. It just makes it a lot easier to kind of embrace a very tough situation.
I think that's well said. I think it's well said. I think there's two challenges that I face in my practice regularly. The first, and honestly, the first is less so nowadays, it's narcotics. And the second is my work comp population regarding return to work. My strategies are both noble and lame at the same time. The noble strategies.
Chuck Goldfarb, noble and lame. I mean, that should be on social media for you, I think.
Others might say just lame and lame. The quote unquote noble part is be honest, be upfront, discuss challenging, predictable scenarios early. I talk about narcotics. I talk about the fact that I'm not a pain medicine doctor. I talk about the fact that I'm going to give them X number of pain pills. I think it's going to be more than sufficient. I doubt I probably won't give you refills. And I say it's just not what I do. And so you can't expect it. And that's the noble part. Talk up front. The lame part is sometimes I blame others. I'm not allowed to give you continuous refills of narcotics, which I kind of think it's true, but maybe it's
Have
stretching
you
the
seen
truth.
the news? Have you seen Nightline?
Yeah. And for work comp, I have to send you back to work at this time interval. It's what we
Yeah.
have to do. It's my obligation to say what you are able to do. And I try to share those thoughts.
I think that I'm thinking about a challenging work comp patient I had recently who objectively, not, I mean, I guess not objectively, but by my assessment has done very well from surgery, but doesn't want to go back to work. And I can see maybe an argument about why they don't want to go back to work, but I'm like, you should be back at work. And I actually asked this is where our therapy colleagues are really, really helpful, just because the amount of time that they spend with patients and how frequently they see them, their relationships are just so much stronger than what we have, given the short amount of time we spend with people. And that's where I lean on our colleagues for that. Yeah, because I walked out of the room, I was like, something's going on here. I'm not quite sure. They probably should be back at work. And can you help me out with this?
I think that's a good point, but I would flip it around as a cautionary tale. If you have a relationship with a therapist, or if you have a relationship with a athletic trainer or whomever, I think we have to be careful to not let their words influence us negatively as we enter into a
Oh,
relationship.
sure. Yeah.
So especially like a new patient, if someone comes in and the therapist says, this guy doesn't have anything going on, it's inevitable that I walk into the room thinking this guy doesn't have anything going on, which is the absolute wrong way to approach it. Is that fair?
Yeah, because that's when to be flippant, but when they walk out saying, "Oh, ganglion cyst," I'm like, "Oh, fuck, ganglion cyst." Like, no,
Right.
it totally frames your view of the interaction, and we have to be good about walking in a room and being a blank slate. Whether it's a trainer, a therapist, or a trainee, that has seen a patient for us. Clearly, if you trust the trainee and the trainee comes out saying giving their assessment and plan, and some of our trainees are more opinionated than others, that's going to affect how you go into that interaction. And I think it is important that we are a blank slate to patients when we walk in, as much as we can be.
Right. For better or worse, um, someone seeing the patient before us affects the ultimate relationship. And what I like about it is, with the right trainee or the right therapist seeing the patient, they can answer questions, give engagement, listen, and provide me some insights. Should make my job easier going in. If it makes my job harder, that's unfortunate, but especially true with the challenging patient, because whatever framework has been established is hard to change gears.
Well, one of our trainees has told me that you tell them you are the patient experience. And in terms of, well, it's true though. I mean, like the patient, and you see this as I read my Press Ganey stuff more and more, which, for better or worse, I read it. It really is like the person, the patient will reflect on their experience based on who they saw, how helpful they thought those interactions were. And sometimes if you don't spend enough time with them after a trainee has spent a ton of time with them, they'll say, oh, he didn't even spend any time with me, because honestly, I didn't need to. I need to get better at making people feel like I spend more time with them, making that quality of the interaction better. And yes, in an ideal world, we would spend more time, but sometimes honestly, like you don't need to, and sometimes I don't want to.
It's all true, and that gets to a point we should have an episode about, is just our whole team. And so I'm fortunate to work with a nurse who gets it. And while she's direct in some ways, like I am, I'm not warm and fuzzy. People like her, they appreciate that quality about her. And let's face it, my personality and my clinic's personality is different than your personality and your clinic's personality. And every patient's not going to be a perfect fit for each of us.
But I will bring it to a close by saying, I do love it when your nurse is in my clinic. I have a wonderful team, but it is total value added when she's around. So
And
you made a great hire there, and I know you're working hard to keep your team intact.
well, and I will say,
But if she ever wants to change, you let me know.
what's great about Nermina is that I love it when she's in your clinic too, because she comes back and says, I never want to do nerve clinic again.
Exactly. Well, a lot to think about, Jeff. Thank you for the topic. I think that we're probably going to end up touching on it again at some point soon. But anybody that, if you have a suggestion for a topic, feel free to email us, handpodcast@gmail.com. Tell us on social, leave it in a review. Of course, it's got to be 5 stars. There's nothing less. I think the button's only set for 5. So just keep that in mind.
Thanks for listening, and send us any patient interaction tips you have. We'll share those on the air.
Yeah, clearly we need to learn from them.
if they're good ones.
Exactly.
All right.
All
Thank
right.
you.
Have a good day.